Now we're moving on swiftly to Wolverhampton. If they could come up quickly, please.
Thank you. It's a pleasure to be here today and to present the Vanguard proposal for Wolverhampton. I'm here with colleagues. I'm Helen Hibbs. I'm the Accountable Officer for Wolverhampton CCG and also a GP in the town. I'm here with Dr. Lee Dowson, the Divisional Medical Director for Medical Emergency Services at our Acute Trust, and Dr. Jonathan Odom, the Medical Director of the hospital, and Steve Marshall, who's the Director of Strategy and Transformation at the CCG. Just to slightly set the scene, Wolverhampton is a densely populated urban area to the northwest of Wolverhampton. We have about 240,000 registered patients and probably a resident population of 250,000 because of migrant workers and asylum seekers. We also have a large BME community of about 25% of our residents and high levels of deprivation with over 20% of, we're in the bottom 20% most deprived ward in the country. It's an exciting place to be, and the purpose of being here today is actually that we want to continue the work that we've already started. This is something that we intend to do whether we win this bid or not. We have been working on an urgent care strategy in Wolverhampton for some 2 to 3 years now and have undergone full public consultation on this strategy. The strategy was launched a year ago with the being signed off by the Health and Wellbeing Board, by the CCG, by Health Scrutiny and also by the Acute Trust. It has all partners on board and has been widely accepted by the population and the public. We started this journey to make a difference in Wolverhampton because we know that too many patients attend A&E, too many patients come to the hospital with ambulatory care sensitive conditions, and too many patients in Wolverhampton end up in residential care. So I'm now going to hand over to Lee, who's going to tell you something about the model that we propose to make a difference.
Thank you, Helen. So, as you said, I'm a Divisional Medical Director. I'm a General Physician, which is my new title. It used to be a chest physician, but I now consider myself a General Physician. And I'm a clinical leader, and my main challenge here, I think, is really around getting my clinical colleagues to change the culture. We have a vision really for integrated care across Wolverhampton, integrated urgent care, with the first principle being that care should be delivered closer to home, or as many of you will have heard, the home first principle. And what that means in reality is that for patients, whether they have physical or mental issues, whether they're sitting with a GP, whether they're sitting with a paramedic, whether they're sitting with a community matron, or if they're sitting on a ward and no longer benefiting from being in hospital, that they have other options, safer options, and options that they will appreciate more, that they can explore and be rapidly signposted to. We're starting from a good position. Firstly, we have a single point of access called WUCTAS. It isn't perfect, it needs to be improved, it needs to have, I think, more senior clinical input, and it needs to be co-located so that works. We have a very well established community teams that do home antibiotics, they do re-enablement, physiotherapy, rapid access to social services, etc. And one of the advantages we have is that they are vertically integrated teams with our trust, which means that we're all on the same team to start with, and we're all pulling in the same direction. We have specialists working 7 days a week across the hospital and offering hot clinics in all the specialties. And what that means is that wherever you are within the system, you can phone a friend and get advice where it's appropriate, or arrange an appropriate to go and see a specialist appropriately and in a timely manner, rather than bouncing through the traditional system. We're just about to open a new £36 million urgent and emergency care centre, which incorporates accident and emergency, acute medical unit, a GP-led urgent care centre, a CDU, and the final part of the jigsaw is an ambulatory emergency care centre, all within one location. But obviously a building doesn't solve all of these problems. The key to this was really working more closely together and having senior decision makers at the front door, and we have a model whereby we've handpicked physicians with the right culture and the right attitude to ambulatory care to work very, very closely with those emergency physicians and to make those decisions right at the front door and rapidly triage people to the appropriate area with as few steps as possible. In many cases, that will be the ambulatory care centre, and we've already established that model treating patients with ambulatory sensitive conditions. But it's quite clear from talking to anyone around the country who's doing this is we now need to move to a much more generic model, not based on narrow pathways which tend to exclude patients, such that you could start with the presumption that this is ambulatory care and you only pull the few people out of ambulatory care into the hospital who need it and the majority go elsewhere. Central to that, and the hardest nut to crack perhaps, is how you do that for the frail elderly. And we will, as part of that, we'll have daily input from our multidisciplinary elderly team. We already have a home interventions team which is elderly care led and goes out into the community. No patient will leave our service without being better educated, and I say by patient I mean patients and carers. So we have discharge bundles in place for most of our conditions already, and that needs further enhancing. In summary, we'll have one single team that can introduce these changes at pace, and will provide patients with the right care at the right time in the right place, and they will leave our service better equipped to deal with their health in the future. Thank you.
Many thanks. Many thanks to Wolverhampton. Now questions, and I've got a question first of all from Sam.
Hi, thank you for that. Can you let us know what your unique selling point is? So, and forewarning everyone else, I'm probably going to ask the same question because there's a lot. We're all going to be saying the same thing today. So, why Wolverhampton?
From my point of view, we're part of the way there. From the second point of view, we're a very tight-knit team in a relatively small geographical location that is vertically integrated, so that we can, we're introducing best practice at pace. I think is really where our advantage is.
And in addition to that, we're going to do it in the hospital setting, in a new urgent care centre, but also on a locality-based model as well.
I'm Jackie Cornish, NHS England National Clinical Director for Children, Young People and Transition, who seem rather like the observations from my colleague who's the President of the College, rather absent from your model. So in your hand-picked physicians, have you considered how you're going to deal with the urgent and emergency care demands of children and young people, first of all with physical ill health, and secondly with mental ill health crises?
Yes. So we already have a paediatric assessment unit, and we already have consultants in A&E who are paediatric trained. So as part of the urgent care centre, that will work in the urgent care centre for acute physical ill health. Alongside that, we're also doing a whole review of CAMS services in Wolverhampton. So we're doing a lot of work about early help and providing CAMS tiers 1 and 2 alongside 3 and 4 in the Wolverhampton economy. So this work is going along in parallel, and we'll all knit together nicely in the urgent care centre.
As regards mental health, we work closely with the mental health teams. We currently have presence of the psychiatric liaison team till 10 o'clock within the the A&E department and the acute medical unit. Now, clearly, we need to be doing more to avoid them even hitting that point. So that's something to take forward with our partners, really, going forward. But as I said, if it's it shouldn't matter whether you're adult, child, mental health, physical. The process of having this all integrated around an ambulatory hub where somebody can put you in touch with the right person very, very quickly is the principle we're working to.
Hello, I'm Philip Barlow from London. I'm a patient. I did notice in your bid that there is a lack of mention of pharmacy, especially with your urgent care centre. I'd like to see more use of consulting prescribing pharmacists who can certainly deal with a lot of the problems. And I think you need to use the expertise of pharmacy a lot.
Yeah, okay. That's something we're looking at as well, more in the primary care setting, but also it could be looked at in secondary care setting. But we have a federation in Wolverhampton, and the federation is looking to employ clinical pharmacists who will then work in our GP practices. So I absolutely agree with you that is a very good way forwards for improving the care of patients with long-term conditions and making sure that their management is absolutely as good as it can be to prevent admission to the hospital. So that's another work stream that we're looking at to bring into all this work together.
I think it raises another point about the different skill mix we use. It's been highlighted by the previous presentation that we haven't got enough elderly care physicians and ED doctors to run these systems. So our ambulatory emergency care system will be joint led by general practice and acute physicians, and I've seen the principal workforce there will be ACPs supported by those professionals, and that would include pharmacists.
Okay, I'm Biwi, National Clinical Director for End of Life Care in NHS England. My question relates to informational continuity and what arrangements you have for sharing records and information across different sectors, including social care.
Okay.
Sorry, I'll answer that. We're in the process of finalising a system called Fibonacci, which will give an overview summary of both health and social care records, which will be access controlled, so that as part when multidisciplinary teams are working together, the clinicians will be able to see both health and social care records, but when the social cares are going in isolation, they can only see the social care records. And that's governed under information sharing agreements we have between primary care, secondary care and social work. So that's already in place and is due to implement in the 1st of October.
Can I say we already have end-of-life care MDTs, which as soon as that's finished that afternoon, there is a record of that available on our clinical web portal, which is viewable to all the practitioners across Wolverhampton.
Thank you. Jo Bibby from the Health Foundation. I heard a number of things in your presentation that were talking about essentially some of the flow methodologies that you're obviously applying. In terms of making change happen, having clear methodologies are important. I wondered if you could just expand a little bit on the approaches you'll be taking.
So around improving flow in hospital, we have introduced daily discharge huddles that occur on all wards. There is 7 daily ward rounds. There's 7-day consultant ward rounds on every medical ward within the hospital. There are bed meetings 3 times a day. There are we have various incentives and whips, if you like, around seeing how what the discharge rate is on different wards and at which times of day. And we've seen some progress with it. I mean, what's absolutely clear to me, particularly around 7-day working, is that you can't just put consultants on wards and expect 7-day working, to realise its full potential. It has to be an absolute whole system approach, and that's what we're working towards.
Thanks very much. Thanks very much indeed to Wolverhampton.